Hi, everybody. This is Joe Procaccino. I am the legal advisor to the Department of Defense Medical Ethics Center, and I'm privileged to follow Professor Giordano's presentation, trying to give you a practical application of the many valuable philosophical points that Professor Giordano passed on this morning. And as you might imagine, being a lawyer, you might look at this presentation and think it being the ultimate oxymoron of a lawyer speaking about ethics, not to mention medical ethics. But as Jim pointed out, it's extremely important to understand the bridge between ethics and the law and how they do intertwine. Because without one or the other, we wouldn't really be able to accomplish many of the decision-making kinds of things that we have to do inside the medical setting. So with that kind of as a background, first of all, just a quick disclaimer that this is being done in my academic capacity and not necessarily representing any governmental position or policy, nor have I received $1 million from USU to be able to give this presentation today. But jumping right into the meat and potatoes of my discussion today, I want to follow on with a couple of points that Professor Giordano mentioned, talking about the concepts of utilitarianism and deontology, but from kind of a more hands-on standpoint. As Jim pointed out, utilitarianism, an action is right if it leads to the greatest possible good. And there's that right that he kept talking about there. But a number of people would reduce this perhaps to saying the end justifies the means. But that being premised on the fact that we're always hoping to have a good end in what we do. So as a provider of care, your ultimate good, obviously, is making the patient better, obviously also achieving the military mission, because we are talking about military ethical ethics, and we kind of hope that those work hand in hand, needless to say. But you're the kind of person, as a pure utilitarian, that you will climb any mountain, you'll swim through any ocean to be able to achieve the ultimate good that you want to achieve, and nothing will get in your way. The deontologist, on the other hand, is also trying to get to that ultimate good, but the deontologist purely is thinking that if there is some kind of moral pause or qualm that they have in getting to that end, in other words, if the means of getting to that end creates some kind of moral dilemma to them, as good as the end is, do you want to go there? Now, I would suggest that it would be very difficult to find someone who's purely a utilitarian or purely a deontologist. I know that ethicists love to use many years ago of an example during World War II of a fellow in Europe that hides a refugee from the Nazis in his attic. A few days after the hiding of that refugee, there's a knock on the owner's door. And when he opens the door, there's a Gestapo agent there who says, "Are you hiding a refugee in your attic?" Now, the pure utilitarian has an ultimate goal of what? Obviously, saving the refugee. So what would his or her answer be? No. However, the pure deontologist, even though they would like to save that refugee, in saying no, is committing a moral problem here. In other words, they're lying. Now, is the lying here of such moral significance that it would supersede the ultimate good? And this becomes quite often a dilemma that I think providers face in making decisions. This can go one way or the other. Look, for example, within the medical setting of someone who is in an end-of-life state at this point, and the subject, say, of euthanasia comes up. Now, euthanasia, coming from the two Greek terms, eu, which is good, and thanatos, which is death. Now, we all want to be able to achieve a good death for somebody who's in an end-of-life situation, but how is that done? Now, if the ultimate good is you'll do anything possible to get them to achieve a good death if they're in pain and suffering, do you do it by an act of commission, or do you do it by an act of omission? Omission maybe being not starting respiratory care or ventilation or those kind of extraordinary means, or removing those kinds of means. Or would you do something more direct, like an injection of morphine, an ultra high injection of morphine to accelerate the death of the individual. And in one case, as we well know under the law, that would be considered a homicide, murder, where in the other case, it may be considered medically acceptable. And we seem to distinguish that by utilizing commission versus omission. But it emphasizes the fact that if you are morally opposed to causing the end of someone using some kind of committive means of getting there, then the deontology in you begins to come out. So you see this dilemma that I think a lot of providers are going to have with a lot of medical issues that may come to the forefront. These two terms then lead into ones I think that most people become more familiar with. These are the big four. Autonomy, of course, is right of self. And in the law, we usually see this right of you to determine the outcome of your own body in the form of informed consent. This is where the patient has the ultimate right to make a decision about what she or he wants done with their body. And as a matter of fact, some would argue that unless that permission is given, you are essentially assaulting that patient. That's why it's so important to follow the rules of informed consent. So when the consent is given, it is indeed complete and informed. But it shows, and our laws and our policies today give great deference to the ultimate authority of the patient to make ultimate decisions. Now, along with this, and I would suggest to you quite often in conflict with the concept of autonomy, is the concept of beneficence, which I would put more in the hands of providers. This is from the Latin benefacere, to make or to do well. And under these circumstances, of course, the goal of the provider, as we mentioned earlier, is to do well by the patient to try to make them better. But as you all well know, what you as a provider believe may be in the best interest of the patient may not necessarily be what the patient believes is in the best interest of that patient. Posit, if you will, the Jehovah's Witness that comes into the emergency room with blood gushing out of their stomach. You as a provider know that with a transfusion, you might be able to save their life and to do so without any other incredible intervention. But they look up with you because they happen to be cogent and have capacity to speak and clearly say to you, I'm a Jehovah's Witness. I cannot accept the blood transfusion. And if you give me one, I may be denied everlasting and I refuse to take it. Based on that autonomous decision by a competent individual, even though you want to exercise the beneficence of making them better, you may have to stand aside and actually watch them die because of the balance and how society balances the right of autonomy here, superseding in many instances the beneficence that you would like to render. This comes into play quite a bit when you're dealing with situations where you, because of your healthcare knowledge, believe that you may know more than the patient and they just don't appreciate what is being said or advised or recommended. But again, we have to recognize the legal and ethical rights of the patient under the circumstances. Again, as a quick example, imagine, and these are actual cases, of a woman that comes into the hospital after being in a terrible auto accident. An x-ray reveals that she has a broken neck. However, the nature of the break is such that she can turn her head, she can stand, she can walk, talk, and move normally. But the neurologists have determined that if she moves her head the ever so slightest wrong way, she will die. Because of this, the neurologists and neurosurgeons recommend the implantation of a stainless steel halo around her neck and shoulders to be able to stabilize the head and the neck until the bone is able to stabilize itself. They explain this to her and the importance of it, and she signs the informed consent and has the halo implanted. 2 or 3 days later, she comes back to the hospital screaming bloody murder. Take this damn thing off of me. I can't stand it. It's painful. It's uncomfortable. I can't sleep. I don't want it on anymore. You put it on me, doctor. You take it off. The doctor responds, I cannot do that because it violates my standard of care. If I take it off of you, it's likely that you will die. This is my decision, doctor, not yours. You put it on me. I'm telling you now, you take it off. Can you see the problem here between the autonomy of the patient versus the seeming beneficence of the physician in trying to make this person well? It doesn't always meld. Further complicating this, of course, is the issue of non-maleficence, which is that Latin maxim primum non nocere, first do no harm. And that's really the mantra, of course, in the healthcare profession. You want to make people better, but at the same time, not harm them. But when we're dealing, obviously, in an environment where there's going to be combat, where there are going to be other issues, including potentially research, and you may be asked to participate in certain research activities where, in order to achieve a higher good, say with non-lethal weaponry, that you may be asked to participate in studies where people are actually having pain inflicted upon them. Now, is this ethically proper for you to participate or not participate? Or could you argue utilitarianistically that because the ultimate goal is to avoid having to use lethal weaponry, that you're actually achieving a good? These are all awkward situations that quite often providers may go to in trying to balance these ethical principles. The final one is the concept of justice, not the legal definition of justice here, but I'd suggest the ethical definition of simply treating people equally. Now, in the distribution of healthcare, we would like to think that it doesn't really matter who the person is, that care is going to be given regardless of that person's background, race, religion, economic situation, all of those things. But, again, we have to be honest with ourselves. Is this really true? Have we not seen, even in recent months here, this issue of justice being raised with COVID-19 and whether or not the care and even the vaccines that are being distributed were being distributed equitably in all regions of the United States with all economic statuses of the United States? And these kinds of problems really provoke the question as to whether or not there is a certain bias or prejudice, whether it's based on certain geographical regions or certain economic reasons, or whether race becomes a factor as well, whether sex becomes a factor as well. All those things are put into play with justice. And again, since we're dealing with the military, we'd like to think that in our military facilities, all of our patients are being treated equally. But then we also ask ourselves, what about those VIP wings at the hospitals? What about executive medicine? And are we giving the retired four-star general deferential treatment that may not be to the same degree that you would give to the sergeant that comes in for care? Would it be a higher degree that's being given to that person because of their grade or rank? Now, can you justify that because of maybe mission issues? But if there's not a mission issue involved, should grade or rank alone justify a differential of care? These are the kind of things that really one must consider or think about when we talk about the principles or ethics of practice. Now, all that having been said, I think it's further complicated, particularly for those that are working in the military healthcare environment, to have this conflict quite often between your personal ethic versus your professional ethic versus your organizational ethic. Now, let me translate this into English if I can. Let us say, as an example, that you have a neighbor that moves in next to you. And when you look out your window, when you see them in their backyard or maybe through their window, they are saying, exhibiting, doing things which really scare the heck out of you. And you really don't want your family anywhere near this person because you kind of have some really concerns about this person's just makeup and the way they exhibit themselves and the way they act. In fact, you might want to pick up the phone and call the police just because you're concerned about what they're going to be doing in the neighborhood. That's your personal ethic because you want to protect yourself and your family. But then, let's just say hypothetically, you go to medical school, and to make it even more significant, you specialize in psychotherapy. And when you get that license, you hang a shingle out your window, and the first person that comes in as a patient is, guess who? The next door neighbor, who ends up sitting down and ends up revealing and confirming to you all of the suspicions you had looking out your window at the backyard and seeing that person exhibit the activities they were exhibiting. Well, now you have the evidence. You've got the admission from the patient confirming everything. Now you really want to pick up the phone and call the police. But can you? Or do you have a provider-patient privilege which may prevent you from doing that? And if you do have a privilege that prevents you from doing that, and there's no exception to that, what happens then if you end up joining the military and then the commander comes to you and says, "Excuse me, doctor, but Private Procaccino has been acting kind of strange recently, and we're about to be deployed. And I'm really concerned about whether Procaccino's just antics and activities may be detrimental to the unit effectiveness and the organizational mission over here. I really want to know, does he have something wrong going on with him right now?" Now, your professional ethic just told you, "Excuse me, I've got a privilege here. I can't say anything to you." But your organizational ethic may dictate to you that you reveal, even though it's minimum information necessary, certain medical information about Procaccino, because the mission here and the success and importance of the mission and unit effectiveness and unit fitness may supersede the professional ethic of the privilege and confidentiality between provider and patient. And this creates problems in a military concept with dual loyalties, because not only are you a provider of care, but you're also a member of the military and may have certain obligations in this regard. And because of this mission, you may have limits on doing no harm, because by revealing certain information to that commander or to other individuals, you could actually then exacerbate, say, the mental health condition of the patient who relied and put trust in you to keep that information quiet. You also have a problem within the organizational ethic of potential conscience clause considerations. And here, for certain very sensitive kinds of procedures, such as abortion, maybe birth control, and we see more recently issues involving transgender and gender dysphoria, whether or not there are providers that believe, either because of religious bases, because of their own personal philosophy, that to participate in such kind of care would be anathema to their own feelings or belief. And the law may actually allow them to beg out of that kind of care, even though their professional ethic would say not only is it acceptable, but it is something that you should be doing. So again, you can see the conflicts that are constantly there for you to have to try to overcome in making decisions. Now, because we are dealing with the law and discussion of ethics here, I would suggest to you that we have to be concerned about the challenge of legal perimeters. Now, I mention this to you because those of you that have or will participate in ethics committee may notice that there'll be a legal representative there. Now, the challenging part of having a lawyer on an ethics committee is that quite often when a case comes up, whether it's end of life, whether it's informed consent, that type of thing, the first thing that the entire committee is going to do is lean over and face the lawyer. And the question that first comes up is, say, is this legal? Now, the sad part of asking that question is that if the answer comes back no, then that's going to stifle ethical discussion. And while the legal opinion will set up a perimeter, it shouldn't be a blockade to keep discussion in, because the law, even though it may be black or white as far as what can or cannot be done, may also allow some fungibility here and allow people to have other considerations or workarounds to maybe answer some of the ethical questions. And so while there are perimeters that are discussed, that it should not be the end all of ethical discussion. The legal status of decision makers, too, become very, very important here, because they would include potentially the providers and the facility. They may have their own feelings about things. Then, with or in conflict with them, you may also have the patient. Remember, autonomy being the decision maker here and having a legal status to make decisions. And if the patient is not competent or have capacity, perhaps it could be the family. Other might include a legal representative or even someone that was appointed by the court. I know that Jim was wonderful discussing a number of Latin legal maxims, and I'm reminded of one by Terence, quod homines tot sententiae, which says essentially that there are as many opinions as there are people. And this is very true because when you sit down at a committee like this or a decision has to be made, you know there's going to be more than one side of a story. And it is so important for us to be able to consider all of the different angles, not only the law, but also medicine. And I would also mention to you at this point the incredible importance of looking at other people that may have significant input in here, including, say, the chaplainate. And I do know that there will be separate discussion later on from chaplain experts as to the spirituality issues that may come into play, that may influence ultimate decisions that are made. And that's why when we talk about these issues, that there are so many, including external factors, because we have to look at variable standards of care. I mention this to you because, again, if we use the example of end-of-life decision-making, there are different states and different countries that may have various standards of care as to how one may end up withholding or withdrawing life-sustaining care. There are still countries where we have medical facilities and bases where in the country itself, if you withdraw life-saving care, it's considered murder. And we have to give respect to the host nation laws. So all of those must be flavored in to any kind of ultimate decision that's going to be made. Now, all that having been said, Professor Giordano used another very, very important word in ethical discussion, obviously, veritas. Quid est veritas? What is truth? And when we talk about truth, it's important for us to be truthful in making our decisions. Now, it's an easy thing to say, of course, but the problem here is what is truth and how do you tell the truth? As an attorney, I would tell you until around the year 2002 or 2003, if there was a malpractice case and a client were to come, the lawyer would end up telling the client, don't say a thing to anybody about what happened in this case until we get through trial. The idea is silence. But after the IOM reports on medical malpractice, and the Veterans Administration began to do studies and began to realize that transparency and truth-telling with patients was very, very important in establishing trust and actually mitigating medical malpractice cases. And that's why it's incredibly important today that when you do deal with colleagues and also deal with patients, this element of truth becomes very, very important. That having been said, of course, truth ends up involving the use quite often of situational ethics. You want to tell the truth, but you also have to look at the situation in which the truth is going to be rendered. And then how do you tell that truth? Do you not tell it by omission? Do you actually commit a lie? Or are there other ways of doing this? Think about this in your own personal lives, about economic loss or gain. If, for instance, you were at a store and you were given more change than you were supposed to when you purchased an item, would you immediately return the money? But if the salesperson was a particularly abusive person to you, would that give you some kind of justification for not returning the money? The fact that you bought it from a multi-billion-dollar store chain as opposed to a mom and pop store have a difference as to whether or not you would return the money or pocket it. Some people use that as an economic justification. The de minimis event. Years ago, a dentist calls me and tells me that he was checking the teeth of an active duty member, and he noticed a cavity in one of the molars. He ends up saying, I can fill it now if you want it filled. And the member said, sure. So they gave him the Novocaine and he put the drill in there and drilled and couldn't find the cavity. Held up the x-ray and realized he'd made a mistake. It wasn't a cavity in the molar. It was a shadow coming through a window that hit the x-ray at an awkward angle. But of course, the patient was there with the Novocaine and had the clamp in his mouth there. And the dentist went ahead and filled the tooth. The patient got up, shook hands, left. There was no money involved because it's a military hospital. And later on, the dentist says to me, should I have told him? Should I have told him I made a mistake? Now, would you have told him? Now, the question becomes, well, sure, you should tell him because you made a mistake. But the dentist is also thinking, but if I tell him, I might be sued. I might be sued for a filled tooth, and he's not going to know the difference. What difference does it really make? It was de minimis. It was just a small filled tooth. Well, where do you define the borderline of de minimis before it no longer becomes minimal, but becomes something significant? A microscopic dot on a lung x-ray that ends up becoming adenocarcinoma? It's very difficult for us to be able to draw that line. What about the fait accompli? What about situations where your facility decides to do a quality assurance look back on medical records of patients that died, and you discover one medical record of a patient that died 5 years earlier, an elderly dependent spouse who you thought died of natural causes, but when you look at the medical records, immediately realize that there was a terrible malpractice that was performed. How many facilities do you think will pick up the phone 5 years after the death to try to find surviving family members and tell them what had happened? It's the truth, but do you want to go there? Or because it happened so much earlier and everybody seems satisfied with the result, you don't want to rock the boat? The vindication mentality. Quite often you're trying to be able to get some justification for things that were done wrong to you in the past. And how do you do this? Well, this is, I like to call the Coke machine syndrome, where maybe you put 2 quarters in a dollar machine, and after the first 2 quarters to get the Coke, the can comes out. Now, do you put the other 2 quarters in because you want to be honest, or do you say to yourself, I've lost more quarters in this machine over the past 6 months. I'm suddenly just getting some of my money back. Well, is it wrong? Is it right? Notice how you're suddenly playing judge in the back of your mind. And then there's the higher good argument. The higher good argument says to you, well, maybe I can fudge the truth a little bit here because there is a higher good, that if I come right out and tell the truth, whoa, I may have a problem. This can also be utilized in informed consent with what some people call physician discretion or therapeutic privilege. And this is where, when a doctor knows that a patient has a certain, particularly, say, psychological situation where telling them the absolute truth would exacerbate that situation, which could end up resulting perhaps in a stroke, maybe you want to tell the absolute truth. Maybe you want to massage it a little bit so it doesn't come out exactly the way that's going to cause that kind of exacerbation. But how far do you go before it is no longer absolutely the truth? This also becomes a problem, you'll notice, in the military, and I would suggest, as far as look at our efficiency ratings every year for promotion, that when people are given their ratings annually, have you ever seen anybody get a bad rating? The way people seem to be promoted these days is not based on the front page of the evaluation, but on the back, where you've got a rater or endorser that's suddenly saying Dr. Procaccino is a really good surgeon. But because you used really instead of absolutely, that becomes a buzzword for someone to say, oh, he's only really good. He's not absolutely good. That means we're not going to promote him. Is this the way that we're conducting ourselves? And this is why somebody on the outside may end up hiring Dr. Procaccino because of that rating, not understanding the subtle game that goes on inside the military, and I end up killing a patient on the outside. We've got to be very careful about how we present and misrepresent and skew the truth. Notice with COVID-19, once again, how various personalities we've seen over the past year have been accused of misrepresentation. Anything from Dr. Fauci, who was accused of saying at one point, you don't need to use a mask, and then suddenly saying you need to use a mask. And when asked why, he said initially you did not need to use one of the answers he gave in a report to a newspaper that from Wall Street was that we didn't want to cause a shortage of masks for providers that may have needed them more immediately. Well, then was it the truth to say you don't need the mask, or should you have come out and said that? But in doing so, would you then have caused a panic? The same thing might apply to when former President Trump made that statement during an interview. Yes, I knew COVID-19 was a problem, but I didn't want to cause a panic in society by saying it. So is causing or avoiding the cause of a panic a justifiable reason for hiding the truth? How far do you go before you end up creating this skewing or misrepresenting of the truth. You got the question of responsibility. When the dentist, I might be sued. And here, once again, you could come back and say pragmatically, but doctor, even if that patient does sue you, how much is a filled tooth worth? Is it $50? And you don't even know if he's going to sue you or not. Because if you're honest, he may say, thank you for letting me know that. And, I'm not really feeling any pain. That's just the way it is. Everybody's subject to error. But then he comes back and says, I don't care if it's settled for a penny because I may be named to the National Practitioner Data Bank, and I don't want to take that chance based on some filled tooth. And that's what the concern of that dentist actually was. Finally, we've got the problem of puffing the truth these days. And I would suggest to you that when you watch television at dinner every night and you're watching, say, for example, a number of the pharmaceutical products that are being proffered, notice how these are being done, that they're kind of being done with subliminal seduction while you're looking at beautiful pictures on the television, but in the background, somebody's saying the side effects of this could include kidney failure, lung failure, death, but you're not listening to that. You're looking at the deer that are jumping over the meadow and people holding hands as they walk to get a healthy dinner. These are the kinds of things that the advertising industry and other individuals are using to mesmerize the patient population into buying a product which may not necessarily be the most efficacious for them because they want to sell the product. And we have to be very careful in educating our population about this stretching the truth like silly putty. But as long as that silly putty doesn't break, the law may consider it to still be truthful. Is it? How do you conduct yourself truthfully? All that having been said, we then move into the issue of professionalism and how this plays out with your proper conduct and moral turpitude. I would suggest to you that our society has carved out a number of professions where they seem to be placed on pedestals. And the ones that I think about would include the healthcare profession, believe it or not, my profession, a legal profession. I would include the clergy in this. I would include teachers. And I would include uniformed personnel, which would include not only military, but also, say, for instance, the members of law enforcement. And you'll notice that when I mention all of these, what's the one thing that ties them together? It's probably the fact that all of these professions could exhibit some kind of authority or power over somebody else. And because of that issue of the power over somebody else in making decisions to keep them alive, to keep them out of jail, to keep them from being arrested, to give them grades in school, that we have to be very, very careful about how they conduct themselves and avoiding the appearance of impropriety. And even though you think that what you do may not be seen or heard by others because everybody else is doing it, you, by the nature of your profession, end up either rightly or wrongly having a higher obligation to watch what you do because people are going to be judging you and judging your profession based on the acts and turpitude that you exhibit in society. When we talk about these issues, too, we need to talk about fairness and judgment in practice. And in here, very, very briefly, I mentioned the term discrimination. The law talks about two types of discrimination, invidious and benign. Invidious discrimination is one for which there is no justifiable explanation. Benign may be a discrimination for which there may be some kind of justifiable reason, believe it or not. Now, on its basis, that if you're discriminating against another individual, the presumption is that it's invidious because you shouldn't be biased against a person or in favor of a person. That there should be, as you see here, an equitable distribution of care. However, the reality is that we do see such situations where this comes into conflict. When we talk about, for instance, the issue of sexual discrimination, we would say that you shouldn't discriminate on anyone on the basis of sex. And yet, posit the following. Female nurse working in the radiology department comes to the chair of the department and says, "Doctor, my husband just called. We got wonderful news. The results came back. I am pregnant." The chair of the department says, "Mary, that's wonderful news. I'm so happy for you. I know you've been trying for a long time." And she, "Oh, we're thrilled, doctor. We're thrilled. It's wonderful." The doctor then says to her, Mary, I tell you what, because we have high levels of radiation in this department, what I'm going to do is I'm going to go to admin and I'm going to see if we can have you transferred to another section of the hospital for the next 9 months just to protect you and that little baby cooking inside of you, because we want to make sure that with the radiation here that nothing happens to you. No diminution in pay, no diminution in benefits. Just want to make sure you're safe for the next 9 months. To which Mary responds, oh, no, doc, I love my job. I want to stay here. To which the doctor says, you're not hearing me, Mary, because if you stay here, there is an increased risk to the fetus inside of you, and I don't want that to happen. To which Mary then says, you're not hearing me, doc. This is my body, and I'm telling you, I want to stay here with my job. Here we have autonomy versus beneficence. Who's going to win on this one? Now, I would tell you that years ago, in an analogous kind of case up at the U.S. Supreme Court, there was a very close vote decision of 5-4 that actually would have ruled in favor of the woman's right to stay in that position. And again, for a lot of people hearing this kind of case, they may say, well, it depends on whose hat you're wearing. If you're that nurse, sure, you should have that right to make the ultimate decision of where you want to work. But if you're management in that situation, and that baby is born with some kind of problem, which could be related to radiation, while you could ask the nurse to sign a waiver, you didn't ask the baby to sign the waiver. And again, it's awkward for management trying to maintain a healthy environment, but not interfering with someone's right to work. How about racial discrimination? What about that 89-year-old woman that comes into the gynecology office for a checkup, and when a chaperone comes in, which is part of the SOP of that facility, she looks at the chaperone and says at her physician, I want a white chaperone in here. How sad it is that in many instances that chaperone will just shake his or her head and walk out and let somebody else come in that is the quote unquote right race. Or the doctor says, would you mind getting somebody else in here? What we should be saying, of course, to that woman is that, ma'am, if you want to be bigoted, do so in your own house, but you don't do that in this facility because we don't sanction that. But what happens if you also know that patient's blood pressure at rest is 240/180, and the slightest exacerbation of that by having some kind of argument could cause her to have a stroke on the table? What would you do there? Some of you might be listening to this and saying, best thing that could happen to her. But others might end up saying, no, wait a minute, that's a problem here. So would you sacrifice the rightness here of saying we don't practice discrimination in order to maintain her health, at least immediately through this particular visit? What's more important here? Can you make an argument of benignity? What's your call? And then we have the issue of confidentiality versus privilege. As many of you know, of course, the Constitution allows for privileges in a number of professions, including, say, the religious in many instances, particularly with confessions. Even in my professional legal profession, that in a criminal situation, that if I'm dealing with a client in a criminal case, that nothing that the client tells me am I allowed to reveal to anybody else without the client's permission. And the only real exception is that if I know the client's going to lie in court, I have to do anything I can to kind of circumvent or avoid that from happening. But then we also have the healthcare patient relationship and the privilege, as we mentioned before. So what then happens when 19-year-old Nell comes into the doctor's office for a checkup? And the doctor knows Nell because he delivered Nell into the world 19 years ago. And he treats Nell like a niece and she treats him like an uncle, and the families know each other. And he notices that Nell is extra happy and extra buoyant today. And he says to Nell, Nell, you're extra happy and buoyant today. How come? And Nell says, doctor, I'm excited because I'm getting married. And the doctor says, I'm happy for you, Nell. Who's a lucky guy? Do I know him? And she says, you might. It's Biff. And the doctor leans back because, yes, he does know Biff. And he remembers he delivered Biff into the world 20 years ago. And he remembers he's been treating Biff's entire life. And particularly from the time Biff was around 13, he's been treating Biff for all sorts of problems related to severe drug abuse. Biff is a walking pharmacy. And Biff is beyond the hope of any kind of rehabilitation. And this doctor is looking at this young lady in front of him and saying to himself, my Lord, her life is about to go down the toilet. Can he say anything to Nell? Interesting. Now, there are exceptions, as most of you know, about the issue of physician-patient or healthcare patient privilege, and it may include gunshot wounds in an emergency room. It may include child or spousal or elder abuse. It may include reporting of infectious, contagious diseases. It may include vital statistics. And in most jurisdictions, it may include something called the Tarasoff Doctrine, which is an imminent threat to a named victim. But again, that imminent threat to a named victim is premised on the fact that someone has specifically said, I'm going to do harm to an individual, which doesn't seem to be the case here with Biff. So can you say anything? This is going to be awkward. What do you end up doing? Not a heck of a lot, unfortunately. And this is a dilemma that, again, a number of professions face. And then we get into the issue of consent. And when we're dealing with the issue of consent, we're constantly battling this issue of doing right with your background as professions and making sure you don't cross that line and suddenly start acting paternalistically, because then you're presuming upon the patient or the patient surrogate. And since we're talking about informed consent, I think it's important for us to look at this, because when you look at the definition of informed consent, as you can see in red, there are a number of buzzwords here that you could drive a truck through. And this becomes the problem in trying to establish whether somebody has really been given sufficient information to be able to give that consent. In fact, look at that first word, sufficient. What does that mean to you? What does substantially mean to you as opposed to the person that may be working with you or your next door neighbor? And then you talk about, what am I going to do to your body? What could go wrong with what I'm going to do to your body? And then what do we hope to accomplish by what I'm going to do to your body? And then what alternatives could I do, and why am I doing this instead of the other alternatives that I'm discussing or I could have discussed with you? Also remembering that the patient has the right to ask questions and the right to refuse. When you deal with these, of course, like everything else in law and medicine, there are going to be exceptions. Some of these are very, very evident to you, and some may not be utilized quite as often. The ones I would just mention to you very briefly, they have particular ethical sequelae from them, may include waiver. This is that kind of patient that comes in and says, doctor, I don't want to know anything about those bad words you're going to use. I don't want to hear the C word. I don't want to hear anything that's going to tell me that I'm going to die or have to have an operation. You do, doctor, whatever you need to do to make me better. I just don't want to hear about it. And when you say, well, Mr. Procaccino, would you please sign this waiver telling us that you're willing to give all of this privilege to me, that I can decide for you? And when I sign that document, wow, very important, but they need to know the implications of signing over my life to that provider. Now, the issue of therapeutic privilege is one I mentioned a little bit earlier, which is where the doctor may be able to skew the truth a little bit in order to prevent somebody from having a problem that they have exacerbated into a bigger problem. But where do you draw the line where skewing that truth suddenly becomes a non-truth? So instead of telling somebody they have cancer, they just say, oh no, you just have a neoplasm. Well, are you telling them the truth? Are you telling them in a way that they'll understand? And yet, are you not letting them down? And then the extension doctrine. What happens when you end up taking out blood clots in somebody's stomach and you notice they have a pink appendix, and you go ahead and you pluck out the appendix at the same time, but they never signed an informed consent to have an appendectomy, only to have the blood clots removed? Now, legally, you can use the extension doctrine to say that a reasonable person would have wanted the pink appendix taken out. But where do you draw the line as to what you can take out? Should it be geographically located next to something that you were consented to remove? Or is it something that's part of the procedure itself? Did you make sure all of this was discussed previously? All of this comes into play with informed consent. Now, when you deal with consent in minors, we have an additional problem, because normally you need the consent of a legal guardian. And that's usually in the form of the parents, of course, but you've got to make certain that the parents are actually the legal guardians or representatives. And this becomes a legal issue that we'll be spending more time talking about, particularly when we're dealing with, say, early side of life kind of care. But when you're dealing with this, you've got to be careful, once again, of not crossing the line into paternalism. I posit the following case to you of a young child 3 years old, the dad brings him in with the kid has earaches in both ears. The pediatrician looks at the child and says, your child has terrible earaches in both ears. I recommend implanting tubes in his ears to drain the infection, to which the dad says, I don't believe in putting those in kids' ears. However, doc, I'll give you a break on this. I'll let you put a tube in his left ear. We'll see how it works. And if it works, I'll think about the right ear. You go into the examining room to put the tube into the kid's ear, and you think about the fact that the father is being obstinate, and you end up putting a tiny tube in his right ear and push it way up out of sight. And the kid goes home and the infection clears up in both ears in a couple of days. But the dad notices a tube fall out of the boy's right ear a couple of days after that and realizes that there was a second tube put in. The dad sues the doctor for lack of informed consent. Now, I would tell you this is a case that the Air Force had years ago, and it ended up being settled for just a nominal amount, about $250. And the reason why it was, even though there was no damage to this child, was that while the pediatrician was trying to act beneficently, the argument was that he stepped across the line and began to act paternalistically. And what he should have done if he was so adamant about the father's obstinacy would be to say to the dad, sir, I think by not putting that tube in your child's ear, you're endangering your child's health. And if you continue to be this obstinate, I think we need to contact social services. That may have been the more appropriate way to deal with this. But again, you've got to be careful about crossing that ethical line. Dealing with consent and incompetent adults, we've also got to be careful about determining, is the person incompetent? And how do you do that? These magic words of capacity or mentation, who are you using to make that decision? Under what circumstances? Is it emergent? Is it non-emergent? And then, was a court decision made declaring the person legally incompetent? Who is the guardian ad litem? What are the decisions that can be made? And then you deal with some of the ethical concepts dealing with incompetency, such as what many ethicists refer to as the Ulysses consent, to which there may be no way to ascertain whether or not the person really means what they say. One of the best common examples might be right now of a pilot who's in a terrible plane crash and is brought to your emergency room. And you see that they're having third-degree burns over 75% of their body, and you're amazed they're even alive. But they're looking up with you, and they're actually cogent, they're actually conscious, and they're speaking to you. And you look at them and you say, oh my goodness, look, we have two choices here. One, I could give you some palliative medication and it'll just keep you calm, but you have no skin left on your body. You're going to get infections and die in a matter of hours. Option two, we have you to get into this hospital and we have to start peeling the dead skin off. We have to sitz baths. We have to go through weeks and months of therapy and grafting and operations. And sir, you may feel no pain right now because the nerves in your body have been numbed by the burns. But in about 5 or 6 hours, some of the nerves that may still be vibrant, when they start to regenerate, are going to cause a pain that no human being in the world could ever describe. But this patient looks at you and says, hey, I want to live. Where do I sign? So you get the consent from the patient. You start treating, and 5 hours later, you start hearing blood-curdling screams. Stop this. Let me die. I don't want this treatment anymore. I had no idea what you were talking about. Stop this. So the question becomes, did he suddenly become incompetent? Did he suddenly become competent? Or does he simply have a right to change his mind? These are awkward situations. And in cases where this has come up, we've seen it go both ways, where if you go ahead and continue treatment over the person's refusal, they may come back later on and bring you flowers and candy and say, thank you for taking the decision-making process away from me because it was the pain talking. But others will come back and say, look what you've left me like. Why did you do this to me? I didn't want this kind of care. This is worse than death for me. You didn't listen to me. I wasn't able to give a consent. Wow. And then this leads into the issue of substituted judgment, because when decisions are being made, who makes that decision under what circumstances? Are the decisions being made based on what the surrogate would do if the surrogate were faced with that situation, or are decisions being made as to what the patient would want if the patient were competent to make the decision? It should be the latter. But we see too often particularly in end-of-life decision-making, where someone has been assigned as the power of attorney and had promised to honor that person's wishes to remove a respirator, but when it's your mom and your dad at the last minute, you suddenly have cold feet and say, I just can't do this. I can't kill mom. I can't kill dad by having that respirator removed. And again, what happened to substituted judgment? We also look into this issue of compelling state interests of keeping people alive, avoiding suicide, advancing the medical profession. But quite often, this comes into competition with other issues in our society, including religion and healthcare. And as I mentioned earlier, we're going to get separate discussions from the chaplain about the issue of religion. But quite often, and an example that I used earlier about the Jehovah's Witness with the blood gushing out of their stomach and the issue of transfusion, it comes into conflict with what is considered standard health care, particularly when you're involving children that may not be able to make that decision themselves, but the parents are invoking religious preference, which could be life or death of that child. When do you intervene? When do the parents have superseding right? All of this becomes not only a legal problem, but an ethical quandary as well. And that is why, when we're dealing with this from a legal standpoint as well as an ethical one, how important it is, obviously, to have commitment to what you're doing. And commitment means that you really, when you make your decisions, when you start working with the patients, that you do it wholeheartedly. You act consistently, because when you act consistently with patients, you are exhibiting the ethic of justice, and you're actually demonstrating a sense of objectivity, which is so important because there are so many sides to a story, and you're not showing any kind of prejudice. Obviously, communication with other healthcare providers, not only of your specialty, but others, because people in different specialties can have different expertises to offer. Document, 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 because if it was not written down, many crusty old judges will say it was not done. The issue of humanity, that the patient inside that room is not the patient in 305, but is Mr. and Mrs. Smith, because there, but for the grace of God, goes your mom or your dad or your child, and how would you want them to be treated? And again, the question of integrity, the issue of, if you are going to be honest, to make sure that that issue of honesty is transplanted into everything that you do and who you associate with, so you come across as being someone that can be trusted in the way that you deliver healthcare, both in law and in ethic. Again, as with Professor Giordano, I'm privileged to be part of this. I hope you have just a grain more of stuff to think about than you did before my lecture. I thank you for your patience with me. And I'm going to be passing this on then to our eminent surgeon, Dr. Megan Applewhite, who's going to be looking at some of these ethical principles from a practical standpoint, but also as a clinician, because you as providers are the one that have to put these philosophical and legal issues into practice. You are on the front line, and these are the issues that you're going to have to confront. Thank you. Out.